Here they come. Even though technically it's still morning, I want to wish everyone a good afternoon. We're going to get started in here. I'd like to stop for just a second and hang on for a moment while others join us. We have a pretty nice sized crowd today. Okay, hello everyone and welcome to today's presentation on compliance updates. My name is Don Doherty and I'm the office administrator for HESNI. Excuse me, I want to share some good ideas, or we want to share some good ideas today that will help prepare you for the road ahead in 2022. Okay, thank you everyone for attending and sharing your lunch break with us today. A few quick notes about our broadcast. All attendees, of course, are muted. You can hear us, we won't be able to hear you, but you can communicate with the presenters today only using the Q&A or the chat tools on your screen. If these sections do not already appear, look for their icons and click them to open it. We'll monitor questions as they come in and do our best to address as many as possible as we go through the program. Now I'd like to invite our 2022 HESNI President, Ryan Alley, who has a few things to say before we begin. Go ahead, Ryan.
All right, thanks, Don. Good afternoon and happy 2022 to everyone. I hope everyone in the chapter and all our guests have been remaining safe and your families are safe, during this troubling time. But we are excited to be able to still offer programming, and we're going to get into that in a moment. But before we start, I do want to just cover a couple housekeeping items about some upcoming events for our HESNI chapter. So just around the corner on February 25th, we have the Certified Healthcare Constructor certification through SASHE, and we are leaning towards, usually it's an in-person seminar. This year, it's going to be a virtual offering. So we're going to provide some more information on the time and specifics on the virtual offering, but please mark your calendars if you're planning on attending that CHC or Certified Healthcare Constructor seminar through SASHE. We are going to be facilitating that on the 25th of February. Also, right after that, we're going to be having our March quarterly meeting. There's going to be more information to follow on the meeting contents and the date of the meeting, but it is going to be kind of hosted through one of our trade partners. So we'll reveal more information as it gets closer as far as the specifics again and the meeting content, but just kind of pencil that in for the month of March. That's coming up down the pipeline. And then specifically on March 30th, our annual indoor racing event has been moved from the end of this month to March 30th. We took a look at this and worked with the venue, and just in light of some of the stuff that's going on with the recent surge for COVID, we just wanted to kind of be as safe as possible and kind of hold off on this. As a reminder for those who attended last year, we also did reschedule the racing event. So it's still definitely on, just not going to be in January like it has traditionally been outside of the pandemic. And it will be on March 30th. So we'll continue to push updates and reminders over the next coming weeks as we get closer to these events. But I did want to kind of mention a couple of those items. And then way down the road in May, the annual conference is coming up on the 5th and 6th. And we just want to remind everyone, we have started getting abstracts, but we definitely get a rush a little bit before the conference. So we want to remind you guys, if you do have any presentation abstracts that you want reviewed and potentially approved for presentations at the annual conference in May, please send those as soon as possible. There's more information on the website, hesny.org, about how to submit the abstracts. And if you ever have questions, please feel free to reach out to Don, myself, and anyone on the board about how to get those abstracts submitted. All right, so enough of me talking. Without further ado, I do want to introduce Ann Guglielmo, and she's with CCI. And I'll hand it off to you, Ann, to do your own intro, and let's dive right into the presentation.
Awesome. Thanks, Ryan. Again, I just want to echo Don and Ryan had to say, thanks for spending your lunch hour with us. We know how busy everybody is. I have a bit of a large task ahead of me. I've got about 30 slides worth of content. So please know I will not be reading every single slide, just kind of touching on the highlights. Before the first question even comes in, yes, the slides are available. Don will make them available to our registered members in PDF form so that you guys will have them afterwards. As Ryan said, my name is Ann Guglielmo. I am with CCI. Do fire protection and life safety consulting. I am also your HESNI treasurer. So I am a member of the board, happy to serve. Thank you for that privilege. And enough about me. Let's roll into some compliance updates here. I know that we haven't done compliance in a while with HESNI. So talking about that agenda that I'd like to kind of bite off and tackle, we're going to talk a little bit about the new water management standards that just went into effect. I'm going to touch on the business occupancy standards that went into effect over the summer. I'm going to talk about some COVID survey changes and considerations. I gave similar presentations at the mid and end of last year, and we were calling it post-COVID. But of course, as you all know, every day, I don't think we're post anything yet. So we're just calling this COVID survey changes and some things to think about as you approach your survey readiness for those of you that are due for an accreditation survey. Then I'm going to cover what was released as the top EC and life safety standards from January 1st of 2020 all the way up through October 1, and then Q&A. As you have questions, please feel free to put them in the chat box. We are going to monitor that and try to cover those by topic. I will get to as many questions as I possibly can as we roll through the standards here. So let's kick this off, start off with the new water management standards. This is in your environment of care chapter, EC 020502, brand new section in the standards, never existed before. This did go into effect in January. Just 12 short days ago. For any of you who were surveyed anytime during 2021, the surveyors were talking about these plans, trying to get people ready for them. So they've really been kind of out on the street a little bit, but now the plan has gone into effect and they are subject to score and survey as part of the accreditation process. We highly recommend that you are able to speak to what your water management plans look like. What do you have in place? What have you developed? And who overall is responsible for your water management program within your facilities? If you needed to make any upgrades or changes to your existing water management program, be ready to speak about that. They want to know where you've been, how you've evolved, what's changed. If you have a program already that was in place that met or exceeded their new standards, again, be able to talk about that. One of the best survey tips I think I ever heard and I like to give is that the more you can speak to what your policies and your programs are, the better your survey will be. So just a quick highlight here, EC 252 EP number 1 requires that you have a water management program. It addresses Legionella and other waterborne pathogens. You have to make sure, or the standards language addresses law and regulation. Different states do have different additional requirements, additional nuances, if you will. So they want to make sure that that program is in accordance with the laws and regulations of the state in which that you reside and your hospital is located. We need an individual or a team who is responsible for the oversight and the implementation of the program in general. Those individuals or team members are going to develop it, they're going to manage it, and they're going to expect you to maintain it. They are looking for a basic diagram mapping your water supply sources, your treatment systems, process steps, control measures, end use points. I know that a number of our HESNI business partners at our last annual conference did kind of speak to what these changes are. I know that you have a lot of contractors in place and other vendor partners that can help with this. I have asked Joint to send out some diagram samples or examples. I'm still waiting to hear back, but if I get some of that, I will add it to the slide set to offer that up. That has been an area that I've received a number of questions on, how basic does the diagram have to be? When you look at this flow chart for sinks and showers and fountains and ice machines, that to me doesn't sound very basic. So I know you may have to get a little bit creative here at EP number 2 when you're putting that diagram together. The plan that you do put together, they want you to base it on the diagram and include a full evaluation of your physical and chemical conditions of each step in that process, and any areas where you have potentially hazardous conditions that could occur. They are concerned, obviously, with slow and stagnant water, and Joint makes direct reference to the CDC's water infection control risk assessment in the healthcare setting as an example that can help you start to set up this plan or make changes to your plan that you may have. Under EP2, further, that individual or team also needs to develop the overall plan, process, procedure for addressing the use of water in areas of buildings where it may have been stagnant. Especially during COVID, we have shut down units or we have shut down buildings, facilities, ambulatory and outpatient buildings, for example. Anytime that we have unoccupied areas or temporarily closed units, we want to make sure that we can go back to this water management plan and that it will give you good guidance on what to do in those areas, especially when you're looking to bring them back online. The plan also has to include an evaluation of your patient populations that are served, which I specifically identify patients who are immunocompromised. We also have to have in that policy and that plan monitoring protocols and acceptable ranges for your control measures. This is kind of where you're going to find the rubber meeting the road, right? You're going to lay out what your protocols are. You're going to identify what your acceptable ranges are, what your control measures are, and then we're going to talk later on about maintaining and your overall process for maintaining the system. They're going to refer back to these ranges and control measures to ensure that that maintenance is happening in the big picture. EP number 3 requires that you document all of the monitoring activities. During the annual conference, I spoke with a number of our water vendor partners that are involved in this process, helping several of our hospitals. And the resounding information I got back is, hey, every hospital writes a great plan. But when we go and we ask them what their monitoring activities look like, they can't show us documentation. So documenting the results of those monitoring activities, documenting corrective actions. Guys, this is no different than your utility system, our fire protection system, our medical equipment, right? We put policies and procedures in place to inspect, test, and maintain. Corrective actions and documenting those corrective actions are part of what's required for this as well. The expectation is the same as every other system in the hospital. So making sure that you're documenting those corrective actions and any procedures that you are following if our tests do fall outside of those acceptable limits and ranges. And also making sure that we document what you guys did, how did you back check, how did you retest when those control measures were needed and those actions were needed to be taken in order to bring us back into our compliant ranges in the grand scheme of things. The EC 255 EP3 makes reference to EC 411 EP1, and this is tying back to processes in place for you to monitor and report and investigate that plan, do, check, act idea. And as we making sure that we are checking up on our processes. So if we have a great plan 255 is easily met because your water management plan contains all the information that it's supposed to, but we don't do anything with it. There are other scores in the EC chapter that could tie back to that lack of action, if you will, based on what's in your plan. At EP number 4, that same team or individual that's responsible for the program also has to annually review it. They have to review the program as a whole, much lined up with our policy and procedure reviews that we do. This does set an annual frequency, so you're going to want to make sure that there is time scheduled on an annual basis to go over this. But the team is also required to look at it anytime there's changes made to the water system that introduce new risk, right? This could be adding of a new building. This could be renovations or changes. This could be new features brought in. I know we've over the years have tried to get away from water features, but we're also trying to improve the patient experience and making it a more healing feeling environment. So I've noticed that there have been some architectural and sort of interior design type changes. That might be something that's here. Anytime that we add new equipment or we add an at-risk water system that could generate our aerosols or be a potential source for Legionella, we want to go back to the plan and we want to make sure that that new equipment, the new system has been added to your risk assessment, that the appropriate levels are set and determined, and that we have all of those control measures in place as they pertain to new equipment or new systems that have been added on. The notes are very important within the standards. You'll see here that both TJC and CMS do not require culturing or any other for Legionella or any other waterborne pathogen, but that the testing protocols are at the discretion of you unless you have a specific law or reg within your state that would drive you to make a different decision. They also refer you to standard ASHRAE standard 188, the 2018 edition of that, and the CDC's toolkits for giving yourself some guidelines and some tools to help you get through the program and make sure that your risk assessments are complete. These are the two reference documents we see here, the CDC guidance and the ASHRAE 188 standards. These are easily accessed online. Here you go. Websites here to get you into the toolkits. The CDC's documentation, of course, is for free. ASHRAE is an entity that does require purchase. So I did go online and take a look. This toolkit here is $100. So if you haven't gotten it and you want to, that's a reference for you that Joint has got directly written into their standards as what you can use for guidance overall. So just a kind of a quick wrap up, if you will, on water management. Make sure that as a facility, part of your survey readiness is that you have a working knowledge of what's in your program. Want to make sure that you know the ins and outs of the program. Why did you make the decisions that you do? Why did you risk things into the different levels and breakdowns that you did? What's unique about your facility? What's unique about your maintenance activities or your control ranges? If you're engaging with a vendor partner, please make sure that you're able to speak to how that vendor partner helps you and is engaged, and where the reporting system kind of falls as far as that's concerned. And make sure that we close the loop, excuse me, on any of our corrective actions that we take, those maintenance activities, those testing frequencies. Having our documentation all in line and in order is what's best for the best survey outcome. And then from an infection control standpoint, I just wanted to point out that the COPs that are linked to this score are both at 4241 and 4242. 4242 is the infection control condition of participation. As many of you may have experience with, that is the same condition of participation that our critical airflows, like in the OR, positive negative pressure for bronchoscopy, for example, positive pressure in the OR, negative in bronchoscopy, that sort of thing. That's where that's linked to. We all know that proper pressure differentials is our big CLD trigger. Well, this is linked to that infection control COP as well. So this does have the potential to score out at CLD. Again, at surveyor's discretion, Joint will provide what their guidance is on how the surveyor should assess that. But I think it's important to know that it does have an infection control link, which could lead to, survey outcomes in the grand scheme of things that are what we want to pay attention to. Our clinical surveyors also have the ability to look at this and score for this issue and issues related to their infection control concerns as it pertains to your water management program. So again, having a great working knowledge and a team structure that includes your infection control practitioner is key for making sure that we have a successful survey in this area. So I'm going to move on to the business occupancy standards. And over the summer of last year, Joint Commission released a new set of standards. This is in their LS05 series of the standards. It was a whole new chapter that they added to the accreditation manual that specifically addresses life safety requirements for business occupancies. Joint was looking at business occupancy standards in the ambulatory care setting and the office-based surgery setting. Apparently, they are still trying to decide whether or not it makes sense for them to have a separate chapter in those accreditation manuals. For any of you that were at our annual conference, Herman spoke on this specifically, and that I believe the way Herman phrased it was that they were looking to make sure that the juice was worth the squeeze in those two types of settings. The ambulatory settings already encompass an awful lot of those business requirements. So I think that's still under review. No new information was provided on that particular topic as of yet. The business occupancy standards, as I mentioned, have an 05 numerical prefix. For those of you that have a working knowledge or are inside the accreditation manual, you'll notice that scores in your hospital setting under the healthcare chapter have an 02 prefix. LS02, 0110, for example, is where, penetrations on our fire barriers are scored. Issues with braided wall construction is scored in the LS02, 0110 section. So in business occupancy standards, LS05, 0110, 05, 0120, for example, covers means of egress. Ambulatory healthcare is the 03 prefix. And know that in the life safety chapter, anything that has an 01 numerical prefix applies to all of our occupancy types contained in the chapter. So both the hospital and the ambulatory setting, and now the business setting as well. The previous life safety chapter contain requirements just for healthcare, ambulatory, and residential board and care. So that was our LS02, 03, and 04 series of the standards. The surveyors, both clinical and life safety surveyors, had been citing life safety deficiencies that were found in business occupancies in the EC chapter. There was one kind of catch-all fire safety, as well as free obstructed egress, lack of obstructions, in the means of egress in our business chapter. They were really trying to kind of find a place to throw those. And the EC chapter was really meant to address the management of risks in general. So Joint's intent with introducing this LS05 series was to provide a more consistent approach for this type of occupancy that aligns with the life safety code requirements, similar to that of hospitals. So you'll see that the references in the LS05 chapter get you to chapters 38 and 39 of the life safety code, which are the new and existing business occupancy chapters. It is important too, I think, to notice that not all of the EPs in this LS05 series of standards are provided with a life safety code section reference. They did develop some content within that chapter that you cannot find in chapters 38 and 39. So having a working knowledge of what's in those standards and what's applicable to those business occupancies is important as you develop your plan for success in these business occupancy areas. So as of July 1st last year, mid-year, life safety code surveyors became responsible for surveying off-site freestanding EDs and off-site hospital-based ambulatory surgery locations. So outpatient surgical departments of the hospital and freestanding ED. When we say freestanding, we mean separate from the hospital. The building can contain other occupancies, MOB, for example, ED on the first floor, MOB on the second floor, segregated by the floor space itself, but really just an offsite location. Life safety surveyors were added days for these types of buildings and facilities for your accreditation surveys. So they are considered ambulatory healthcare per the CMS final rule that was put into effect when we adopted the 2012 edition of the Life Safety Code. As such, they felt that a more specialized eye was needed in those locations. The clinical surveyors are responsible for surveying the physical environment in settings that are not one of the three that the life safety code surveyors go to. So they are looking at life safety code requirements and anything that's not an inpatient, so not the hospital, not a freestanding ED, and not an ambulatory surgery site. Those LS05 standards are applicable to all of these. So these are your freestanding MOBs. These are your outpatient buildings that you have sometimes on your main hospital campus, sometimes what we would label as an offsite location. So this LS05 series of standards gives the surveyors, the clinical surveyors, as well as the life safety surveyors, a place to score issues that they find in those occupancies defined as business. All right, COVID survey changes and considerations, some things to think about here. So per TJC, many of you know, March of last year, March 15th, they resumed survey activity. So we're coming up on almost a year of surveys under the belt here. Back at it, they are unannounced. We are the window of opportunity to communicate with your account executive and have an idea of whether or not you're actually survey ready and can come in has kind of gone to the wayside. We're back to unannounced. Initial surveys, so people who are bringing new facilities online for first-time accreditation and deeming, and those surveys that were past due have received prioritization, excuse me, from the scheduling team. If you have multiple hospitals in your same service line or under the same license, over the years, you may have been surveyed separately during different weeks to allow for staff to be present at each of those locations. Because the list of backlog surveys was so long, they are concurrently surveying multiple hospitals within the same system. I have a client who happens to be out of state, 5 hospitals on the same license. 3 of those hospitals were all surveyed during the same week. So the manager, the director of facilities that was over all 3 of those was driving from site to site each day, trying to catch up and be a part of that survey. But that was how they're able to try to fill the backlog and get all those past due surveys done. I did speak with some people at Joint who indicated that they're pretty close to being caught up from that backlog. Only some of the 2021 surveys are left. The 2020 surveys that had all been postponed have all been caught up on, and now they're getting back into the window to catch up on those other surveys. So taking a look at that, if you are due for survey or you're coming into the window, please know that they're trying to get back on track, and our survey readiness activities really should be in place so that you are ready within your accreditation cycle. For those of you that are DNV accredited hospitals, their annual periodic NIO surveys will remain remote until at least February of this year. They had done some things to make some adjustments, and with the uptick in COVID, they had announced that their periodic surveys would stay on that remote platform. They've extended that through February of this year. In accordance with the CMS guidance, they cannot do accreditation surveys remote. All of their accreditation surveys must be done on site. So in accordance with the CMS allowances, postponement requests have to be based on your individual's facility's circumstances. DNV, if you are expected to have an on-site survey in the first quarter of this year, you may request a postponement. That postponement must be based on either your census, your staffing shortages, PPE issues, if you've discontinued elective surgeries, again, due to COVID increases and influx, if you've closed your ED or on divert, that's another reason for postponement, or deployment of a state or federal team. For example, California was utilizing the National Guard. I think that might have happened in New York as well. Deployment of a state and federal team for support is another reason why you may be able to postpone your survey. DMV will look at each of those requests individually. There's no guarantees in the big picture, but based on the way things are going, they are able to make extensions to your accreditation. So work with your account executives if you're in for trouble for that. All right, some survey considerations. If you are surveyed during this process, right? Surveyors are not going into at-risk or confirmed COVID-19 rooms or units. Obviously, surveyor safety is important, as well as uninterrupted patient care. Limited physical review of high risk or aerosol generating procedures, kind of obvious here, but again, trying to reduce all of the risks. May mean a simulation or a distant review of this area. Back in the day, we used to call them tabletops. Might just be a kind of a what if scenario that gets laid out there, and the clinical survey team may talk through a little bit better with you, maybe what a simulation might look like, or a what if scenario that helps them to judge the processes that are in place. All of the CDC risk reduction strategies can be expected. So of course, proper PPE, proper social distancing. And probably one of the bigger changes is the limitation in the number of people who participate in the tour. I've been on several surveys where, we're walking around with 10 or 12 people. The days of that are kind of over, at least for right now. They want to limit the number of people that are part of that physical walkthrough and survey to only those that are really necessary. Document review. So documentation must be complete. This has not changed. I said it during water management, but it really applies to all of your documents. A working knowledge of your dialogue, what's going on with your documents, what's going on with your system, what goes along with your testing. All of that is very important. Having a working dialogue for your document review is just so important, to be able to speak to what you did, how things were impacted, who's responsible, what does all of that look like, is one of the keys to successful survey. I never ever suggest that you provide more information than what's required. Simply provide what each EP is asking for. If the surveyor needs more details or wants more information, obviously provide that information upon request, but we never ever suggest that you offer more information than what is required to satisfy the standard. You want to know what EPs are addressed in the different documents that you're presenting. Our fire alarm reports cover many, many different EPs. And if you're just going to hand over a fire alarm report, you want to make sure that the different information is highlighted for which EP it's satisfying, as this makes the process just go by a little bit smoother. You also want to know what gaps you've had in your testing over the course of the last almost 2 years here. And if you've taken the CMS 1135, have any of those gaps been allowed by that 1135 waiver? Did you use it? How did you use it? And know that if you've applied the 1135 waiver, you have to be ready to speak to not only what was missed, right? We missed these quarters, we missed these months, we missed this semi-annual, but how are you going to get that back on schedule? When is the next time we're going to test it? What's the plan for putting that system back on track and back on frequency, so that we have a better approach to getting a plan in place to come back into compliance with those standards. The public health emergency is still in effect right now. So the 1135 is technically still valid. So if any of you are using that, again, a good working knowledge and being able to speak to it's important. You may run into a situation with missing documentation. The surveyor can allow that as an IOU. If they do allow any missing documentation during that review, know that you're going to have to produce it by at most the end of the day that it's requested. Sometimes they'll tell you by lunch or by 2 o'clock, whatever those timeframes are. You'll need to meet that at the request of the surveyor. You also have to know what's an IOU and because it can't be located versus what's being labeled as an IOU that's actually missing because of that 1135 waiver. So again, if you've taken the waiver, you need to make sure you know what it's applicable to so that you are not held out on an IOU where the surveyor is expecting documentation to appear that might not exist simply because it was covered by the waiver. So again, having a good working knowledge and understanding the ability to speak to where that waiver comes into play. Know that the 1135 waiver is not a complete and total get out of jail free card. It does not permit gaps in testing of our monthly fire pump. Our monthly portable fire extinguishers, does not allow for any gaps for our elevator firefighter emergency operations testing. Your monthly generator and ETS testing is also not covered by the 1135. And if you happen to have any construction activities that require daily inspections of the means of egress under ILSM, you also are not permitted to put that under the 1135. Here are the things that the waiver does cover. Any testing that I didn't call out on that previous slide. Medical equipment, inspection, testing, maintenance activities. Again, if you're going to apply it to medical equipment, hit rates, percentages, location of devices. How many people have had vents that have just been in use since March of 2020, can't get your hands on it, just as an example, but knowing where those devices are and where they fall in the inventory and how we're going to get them back checked and tested to make sure that we are as compliant as possible. Is key to proving success to that, for example. If you're using any rooms for temporary patient care or quarantine that are windowless, that requirement also is covered by the waiver. ABHR quantities and installations. A couple restrictions to that are that anything greater than 5 gallons, we still must store in a hazardous area, regardless if we're taking ABHR quantity allowances. And you also have to make sure that you are restricting access to your at-risk patient population. Again, typically like in your psych setting or your ped setting, we're seeing ABHRs that just popped up everywhere. Hand sanitizer becomes, one of those solutions. So we're using it absolutely everywhere. We've exceeded the allowable limits per smoke compartment. So we want to make sure that where we're putting it, we're not putting any patients at risk by, adding in all of those additional devices. The waiver does qualify under the quarterly fire drills as well. Please know that if you're going to go off frequency, it does require a documented orientation training program that relates to your fire plan that considers what your current facility conditions are. And I would tell you that part of what needs to be considered is if you've relocated entrances or exits, for example, we've disrupted our pathways that staff might be used to as part of their previous fire drill experience. So you have to make sure that you document that you've gone over that program with staff and that they are aware of what the current facility conditions are. The waiver also covers temporary construction. It allows the use of temporary walls and barriers to be put up between patients as part of your COVID treatments. Egress routes. So let's talk about what might have changed here for egress routes. Did we block any of our entrances or our exits? Have we relocated and tried to move our patient flow, especially down around that ED area? We have any changes to our furniture placement? I was down at another client out of state, had a significant amount of waiting room furniture, very large waiting room space where they brought people in to wait for the ED. Of course, reduced what those allowances were because they were trying to put the most amount of space between patients that they could. Excuse me. Where do you think all that furniture went? Furniture had to find a home. Home needed to be out of sight, out of mind. And what they ended up doing was blocking 2 of their exterior exit stair discharges because the patio area that was covered was the best place in their mind to put all that excess furniture, and in turn ended up, creating life safety code deficiencies for other exits within the building. So change in furniture placement. Are we, making sure we're not blocking exits, or we have not disrupted our exit flow from what the building originally was intended and designed for? Did you return any of the conditions thinking you were good, and then with the surge put something back? And any of the mitigations you may have had in place, that came offline, did we bring them back on? And again, re-educate staff, making sure that if you are still consistently doing fire drills, that changes to our egress routes or our layouts have been rolled into what that fire drill scenario looks like, or the training that you provided for staff. Did we implement any changes since March of 2020 that you think are going to remain? Have we looked at what the overall impact to egress is, because we've now essentially done a design change to what that plan looked like? Is your exit signage correct? Have we updated our life safety drawings? I cannot tell you how many facilities now have out-of-date life safety drawings as a result of the changes that we've implemented due to COVID response. So making sure that we get somebody in to take a look at those floor plans and we get those floor plans updated. Remember, the life safety drawings are what the surveyor uses as their roadmap and their guide from the minute they walk in the door until the minute they leave. And you only get one chance. Whatever drawings you hand them are what they're going to survey to and with. So we want to make sure that we are appropriately keeping our life safety drawings up to date and giving the right guidebook, if you will, to the surveyors as part of the process. Mechanical systems. I know this has obviously been a real hot topic. Who's doing what, when, where? What changed as a result of COVID? Were you an organization that needed to take out windows for direct exhaust? Have you had the opportunity to convert any of your units or wings, the entire unit, to negative, for example? Did we create some makeshift ante rooms? Did we restore conditions over the summer, only to now be coming back to some of those? Any of the changes that you implemented in March of 2020, are you going to keep any of those? I have some concerns that we have overtaxed our mechanical systems. We've asked our mechanical systems to do things that they have never really were designed to handle. So where does the risk assessment fall? Where does the ITM activities get adjusted? How have we looked at those in the big picture to make sure that our mechanical systems are everything they should be, and that we're able to rely on them as we expect to for hospital operation? Construction activities and infection control. So prior to COVID happening, there was an increased focus on our infection control mitigations and implementation for our different construction projects. If you're still doing construction, how has things changed for you? Are we making sure that we're assessing those process? Excuse me, that we have in place? Are we doing a pre-construction walkthrough? Are we making sure that we bring clinical staff in on that pre-construction walkthrough? Are we doing our rounding? You know, I review ILSMs all the time. I review our infection control risk assessments and our pre-construction risk assessments that call for daily and or weekly walkthroughs. Who's doing that rounding? Is it a joint effort between you and the infection preventionist? Is it facilities doing their own, IC doing their own, the contractor doing a third, and we shove all the papers in the book and we call it good? How are we following up on any of those deficiencies that we're finding? And I find a lot of them. As a third-party reviewer, that's probably one of the bigger things I see with construction, is that we push that off onto our contractors. We ask our contractors to do all of that, and we don't ever follow up on any of it. When you do your walkthrough, do you bring the contractor's walkthrough with you? Because if you find deficiencies during your walkthrough, were those documented by the contractor? Were they not because he didn't know they weren't deficiencies, or they were deficiencies, excuse me, or were they not because he's just not documenting things the way you are expecting them to do that? So take a look at that. Pressure differentials. I still cannot tell you how many construction sites I walk on that are improperly pressurized, blowing positive into the corridor, dust, debris. And this isn't just open door, airflow changes due to access of the site. This is closed door, set the manometer up against the door, and we see that it is blowing solidly positive out into the corridor space and impacting the, associated adjacent areas. We also want to make sure that we are properly separating the construction space from the rest of the facility. We want to make sure that we have appropriate construction barriers, whether those are hard barriers, again, monitored barriers, checked daily by the contracting staff, infection prevention, and all of those who should be assessing those areas and spaces. Some more survey changes. So there are some environment of care and emergency management survey changes to be aware of. Effective January 1 of 2021, that 1 hour EC sit down was discontinued. They've rolled that 1 hour sit down session into the actual field survey portion of the program, if you will, wanting to give more time in the field and during the review to those particular items and areas. Mm-hmm. The clinical surveyors will also discuss EC topics. They always have. I know this is something that I've worked with a number of clients through. Clinical surveyor during that survey walkthrough with the other clinicians will score something in the EC chapter. And guess who's responsible for responding to it? That's right, you guys, right? So making sure that you understand that that has not gone away, but now that this 1 hour EC sit down session has gone away, we may see some more clinical survey questions that come out of that. Coming up, effective in July of this year, will be the new EM standards with new EPs. So keep your eye out for that for those of you that have emergency management responsibilities. Joint has stated that their goal is to be more robust in their EM requirements and offered more detailed guidance on the different EM activities. I want to put more focus on the preparedness given all of the weather events and things that have been going on over the last couple of years. All right, let's talk about those top. Yes.
Maybe this is a good time to take a pause here. You want to answer, or just I've got 2 or 3 questions here. Maybe
Sure.
Catch your breath. Can you see them on your screen, or would you like me to read them to you?
Yeah, you know what? I think I've got something up here. Life safety code classifies ambulatory as 4 or more patients incapable of self-preservation. My understanding is that CMS defines it as 1 or more. Can I please address how Joint Commission views this? So if you take a look at the CFR, the Code of Federal Regulations that went into effect July 5th, 2016, adopting the 2012 edition of the Life Safety Code, the Life Safety Code, you are correct, it does define ambulatory healthcare as 4 or more patients incapable of self-preservation. The 1 or more that you are referring to is only for ambulatory surgery centers or outpatient surgical departments of the hospital. If you are not an ASC, you don't fall under the ASC conditions of participation, then the definition is still at 4 or more people incapable of self-preservation. So there is the ability to be ambulatory at 4 or more. Again, it's just separate from ASC and surgical center COP applicability. CMS 1135 waiver, temporary construction. For these temporary walls and barriers, do you recommend a basic risk assessment ILSM generated even if no impairment is observed? I would tell you that if you have a process, your pre-construction risk assessment that does facilitate this easily, it's always best to put one of those risk assessments in. There might not be a lot you decide to implement from an ILSM standpoint for temporary walls or construction here. Making sure that we don't obstruct our sprinkler systems and our fire alarm systems obviously is key. You do know that you're going to have obstructions. I would absolutely do an ILSM assessment because that is a known life safety deficiency. Even though we're permitted to create, if you will, these deficiencies under the 1135 waiver, it is still good to know where your risk lies and whether or not there's anything we need to do to offset that risk. So yes, basic risk assessment, I always recommend that we do that whenever possible. Does our water management plans apply to business occupancies? What kind of equipment requires a water management plan? So I would highly recommend you get your hands on that risk assessment, the CDC risk assessment toolkit, if you don't have one of those, or you don't have a good risk assessment plan to work from. The new water management standards are in the EC chapter. Remember EC 02, 05, 02, environment of care chapter applicable to all occupancies, including business occupancies. So yes, you should have a water management plan that would apply to your business occupancies. Now, will that be reviewed? What's the level of detail? I've not gotten any feedback from Joint on how in depth that's going to go. I know their initial focus was on the hospital setting and those ambulatory settings. But again, as a part of the environment of care chapter, just like those clinical surveyors asking for your fire alarm systems testing, this is another plan that could be scored under business occupancies if you were asked about it. Do I see them going there first? Absolutely not. I see this rolling out, just my opinion, but I see this rolling out in the hospital setting and those ambulatory settings initially, and us getting to that business setting kind of further on down the road. But the way the standard is written, technically could be applied to those business occupancies. I think that's everything from the chat box. So we'll talk about the top EC and LS scored standards here. Joint did release this documentation or this top scored standard out of their survey results. These are the top scored standards between January 1st of 2020 and October 1st of 2021. Now remember, March of 2020 until, almost March of 2021, we almost had 12 months with very little survey activity. Only initials and complaint surveys were really being done. So I did not put any information in here about what the top scored standards were from 2019 because I just didn't feel like we were comparing apples to apples. But as you can see up here, and I'm going to get into a better description in just a minute, EC 261, so in the environment of care, 261 is our kind of general catch-all standard. That scores out at the top in the big picture. The right side of my slide here has where the surveyors scored this issue as far as the SAFER matrix is concerned. Now, speaking of the SAFER matrix, here's where the percentages of those top scored standards kind of fell out. You'll notice that a significant number, 55.7% of all of those scored observations fell here in this low limited category. Obviously, it's where we want that to be. We don't want anything to fall into this high or to the ITL category. Those are, bad days for everybody when that happens. So looking at these minor building deficiencies and things that are happening in the environment, this low limited is obviously the target spot where we would like those deficiencies to fall. So just a quick breakdown here of your top 10. As I mentioned, 261, EP1, kind of the catch-all for the physical environment. Remember, for a long time, this is where ligature risk happened for scores prior to the National Patient Safety Goal coming out and then moving those scores over. So this did, I think, encompass some of the ligature risk issues before that migration to National Patient Safety Goal happened. Number 2, LS 2135, EP number 4. This is the infamous wires on sprinkler piping. Anything touching that sprinkler pipe, real easy for the surveyors to find. They pop the ceiling tile to take a look at that fire barrier in front of them and check your penetrations. Look over their shoulder. Here's my sprinkler pipe. Stuff is running right above and hanging on or draped over. So that's your number 2 item right there. EC 255, EP number 6, non-high-risk utilities equipment inspection, testing, maintenance activities, are completed at 100% hit rate. So wanting to make sure that we have, again, I talked earlier about closing that loop, inspection, testing, maintenance. What are we doing to correct those activities? This is making sure that we are completing those activities. All of our equipment is properly maintained and inspected and tested, accordingly. Number 4 here, LX 2135 again at EP number 4. This is the sprinkler system catch-all. Really, I think that the number one thing that surveyors are finding here are obstructions to our sprinkler heads. Where is your signage placement? When you look up and down the corridor, for example, what's the proximity to heads? Do we meet the obstruction criteria as identified in NFPA 13? EC 251, EP number 9. This is that our utility systems are properly labeled to facilitate shutdown. So again, emergency operation kind of at the key in the forefront, making sure that we have proper labels in place. We know what the components of the system are and that we are able to shut down in a necessary situation. EC 221, EP5 covers our eye wash station and emergency shower issues. Blocked, lack of logs, improper testing. I always recommend that we take a look at our eye wash stations and our showers. Are they necessary? Do we have caustics and corrosives? Is there anything that we can do to take a look at what's in use in the area? If you can get rid of them because they're not required, obviously we highly recommend that you do that because it's less inspection, testing, and maintenance criteria, or things for you guys to worry about in the big picture. LS 2110 EP14 comes in next. That's our penetrations in our fire barriers, our fire rated barriers, and our barrier management kind of in general, making sure that we have appropriate barrier management programs in place and that we are properly protecting all of those penetrations. We have always blamed for years the IT guy. There's so much happening with, expansion and change. electronic medical records, all of this stuff that happens from an IT standpoint. So do you have a good process in place to make sure that anytime people are touching your fire rated barriers, that we are properly protecting those penetrations and making sure that they work, that they're protected in accordance with the requirements of the code. LS 2110 EP11 fire door issues. There's a lot of confusion in the field about fire doors. Don't forget, scored out in the EC chapter, EC 235, your annual fire door inspection. Looking at the results of your annual fire door inspection should lead you to a good maintenance program for those fire doors, making sure that they are properly functioning, listed and labeled. The only devices on there are approved for use on the fire door, and that, you know, we are not coming across fire door issues. Real easy thing for the surveyor to sample and easy for them to score. Encouragingly, the 9th scored standard here is EC 251 EP15. This is that critical air pressure issue. This is when we walk up to the OR and we find ORs that are negative, for example. This is where we find excuse me, any of those critical infection control spaces that are improperly pressurized and not being maintained. This is that link at 4242 for infection control, which leads you to a CLD or can lead you to a CLD, which is that follow-up survey within 45 days. Of course, nobody wants the first survey, so having a second survey is something we try to avoid, right? I'm happy to see that this is slipped to item number 9. We put enough focus on it over the years and stress the importance of it. So it's good to see that it has fallen out of kind of that top 5 area and not scored so high on the list. And then rounding out the top 10 here, EC 259 EP number 12 for medical gas cylinder management. You know, we've been beating the drum on this for a really long time. Full cylinders, partial cylinders, empty cylinders. What does your policy say? How are staff, you know, acting in the field? What are they doing with the cylinders? Are they putting them in the right racks? Do we have the right signage? There's so many different things that can go along with the medical gas cylinder management. Probably for me on my surveys, as I am helping to prepare our facilities and get ready for those accreditation activities, just something that, you know, what your policy says is one thing and what your staff is doing is something else. So making sure we're paying attention to those medical gas cylinders is key. So with that, I'm going to open the floor up to some more questions. I see another one that came in here. IWASH station requirements using the SDS of a product or chemical, eye irritation, risk listed category 1, 2, immediately necessitate an IWASH station, or is it in conjunction with risk assessment? So caustic and corrosive, if you read the ANSI standard and you go into the OSHA regulations, caustic and corrosive are what drives it. So if you have eye irritation, there are other means and methods to comply with OSHA's risk management strategies other than a plumbed IWASH station. So I really highly recommend that we take a look at where caustics and corrosives are, and those are the areas we put the showers. If we're putting them everywhere for bloodborne pathogen, or we're just putting them there because the bottle says it's an eye irritant, I might suggest we work with EVS, or we work with purchasing, we work with some of our other safety department, for example, to come up with better solutions that will help to keep you out of trouble from a survey perspective.
Mhm.
Absolutely, I'm happy to help. Thanks for asking the questions. Anybody else have some questions? I actually talked so fast that there are 5 minutes left, which is unusual for me. So I want to be respectful of everybody's time. Again, like I said, thank you for spending some of your lunch hour with me. Plenty of things that you could probably do to take a break. So spending that time with me is appreciated. I will hang out here for a few extra minutes also in case anybody has any questions or anything they want to ask or come through. If you are interested in CHC, I'll just plug that one more time. That is coming up next month in February the 25th. So if you have anybody on your staff that, you know, you're looking to get certified and, you know, help expand their education and knowledge base or get them certification, please keep that in mind.
Hey, Ann, if I may, I know you mentioned at the start of the program, these PowerPoint slides will be available to everyone. In addition to that, we have a video of today's program that We will get both of those items posted on our website and probably in the next day. And we'll inform everyone of when they're available for viewing or download.
Excellent. I do have, let's see. Oh, I didn't, silly me, didn't put my contact information in here, but you can always message me, treasurer@hesi.org, or it's AnnG@codeconsultants.com. Please feel free to reach out to me if there's anything that I can do to help you out. And you know what, Don, I'll add my contact information. I'll put a slide in with my email and my phone number. If there's anything I can do to help you guys as you go through the survey process, you're prepping for survey readiness, you're kind of getting back into the groove of things, knowing that your survey is coming up. I am based here locally in Chicago. I have a full team that can help. So please let me know if I can be of help to you in any way as you kind of work through what you're doing. And for, all of you who are out there in the trenches, thank you for what you do every day. It's such important work. And sometimes it probably feels like thankless work. So please know that we are grateful for all that you do.
Okay. Well, thank you, Ann, for a great talk. And I know it put a lot of hard work you put into this to prepare today's program. I want to thank Ryan also for his helping out today with the presentation. And that's about it. I think we're about ready to go. I want to wish everyone a pleasant afternoon and a safe trip home if you're not there already.
Thanks, everyone. Thanks, Ann.
Thank you.
Mm-hmm.